We're going to get into our first session for today, where we're going to be taking a closer look at pulmonary management. We're going to be joined by some clinicians and patients. So first up, we're going to be talking about PFTs and routine testing. We're going to be joined by Oren Kupfer from Children's Hospital of Colorado, as well as Don and Alex Rizkala. So Dr. Kupfer, I'm going to pass it over to you.
Thank you very much. It's a pleasure to be here with you guys. I'm going to introduce myself. But first, I want to introduce Alex. Alex is a young man from Columbus, Ohio, who's really into chicken. And his mom, I guess, supports that. We're going to talk today a little bit about taking a deep breath, about pulmonary function tests, and a patient's take on pulmonary management. So what we wanted to do is bring the patient's perspective to this. So let's take a look. Next slide, please. So this is the table out of the Lancet article about the diagnosis and management of muscular dystrophy that came out in 2018. This is for pulmonary management. You can see there are three columns about the ambulatory stage, the early non-ambulatory stage, and the late non-ambulatory stage. And that's how we're going to divide up this session. So Alex and I have the part about the ambulatory stage. And you can see there are some very dry details here. Once yearly doing pulmonary function tests, thinking about sleep studies, and using immunizations to stay healthy. That's all well and good, but it's really dry. Remember, we wanted to talk about the patient's perspective. So I want to ask you, Alex, what do you know about breathing in Duchenne?
Well, I know I'm missing part of my DNA that helps with my muscles, and since my lungs are muscles, it makes it a bit harder for me to breathe.
All right. And do you feel anything with your breathing right now?
Honestly, it kind of just feels normal to me right now.
Okay. Well, that's often what we see in the ambulatory stage of Duchenne. Let's go to the next slide. All right, Alex, what you got for me?
Why do we do breathing tests?
Why do we do breathing tests?
So we do breathing tests so that we can see if your breathing muscles, the diaphragm and the muscles in between the ribs in your chest, are functioning well, because you need those muscles to breathe.
Why do we do sleep studies?
Why do we do sleep studies? So we do sleep studies if people are having signs of problems breathing during sleep. Their sleep is disturbed, they wake up a lot, they snore, they sweat, they just don't feel good when they wake up. Oftentimes at this stage, in the ambulatory stage, we're really doing sleep studies to figure out if problems during sleep are related to breathing or if there's something else going on. So it's really just a part of your picture, right? It's not just, is there a breathing problem, but what else could be going on with your sleep? So Alex, can you tell me a little bit about, or Don, if you want to tell us a little bit about Alex's experience with a sleep study?
Yeah, I'll talk about it. Alex had one when he was pretty young, so he actually doesn't remember a whole lot of it. We just have some funny pictures from it. But I'm actually the one who triggered the sleep study. So Alex was probably a little young from a normal course standpoint to have one, but he's always been a kiddo that's had a hard time sleeping. He wakes up often in the middle of the night. He has a hard time getting back to sleep. He had some light snoring here and there, nothing I would say is routine, but we really just wanted to understand if that was related to the Duchenne or not.
So that's a really common picture that we see in kids at this age and stage of Duchenne, that there's some sort of sleep disturbance. My job as a lung doctor is to figure out, is it a breathing problem that's causing sleep disturbance, or is there something else? So a sleep study is really only part of that evaluation. Would you mind sharing us or with us what you learned from that sleep study?
Yeah, absolutely. So for Alex, he actually falls into the group of Duchenne patients who also exhibit some behavior differences based on the impact that the Duchenne may be having on his brain. And what we learned, we were grateful for, which was, and of course, that evening in the sleep study lab, Alex had his best night of sleep ever. And so the people who helped us through that sleep study night might have even been wondering why we were there. He slept pretty sound, didn't move around, didn't wake up. So what we learned actually made me feel a little bit better is that it wasn't Duchenne related for us in terms of the lungs not functioning properly, but it was related to our friend we call the Duchenne brain in Alex. So he's always had some challenges with certain behaviors. And we've just learned that with Alex, we just have a hard time sleeping, getting to sleep, sometimes waking up often in the middle of the night. But for now, it's been deemed as behavior based for us.
So that's really important to know for a number of reasons. One, for a time at least, we can put aside breathing problems during sleep. That may come up later in life, and our colleagues will talk about that later in this session. But it's also really important to find out what it is that's causing those issues. Now you can go forward and gain tools to address those, which I think is what's happened. All right.
Yes. Yep. We use melatonin to help get to sleep. And then we have tools just psychology based to help stay asleep or what to do when we wake up in the middle of the night. So it's just practicing certain behaviors to get back to sleep.
Awesome. And those are tools that Alex can use throughout his life as well. So it's not just for now. It's actually a nice set of skills to be able to build for the future.
Yeah.
We all can use those skills.
That's true.
Hey, Alex, I think you had another question for me.
Yes. What is pneumonia?
That is a very important question, especially in muscular dystrophy. So pneumonia literally means an infection in the lungs. It could be because of a virus or a bacteria. The reason we worry about pneumonia in muscular dystrophy, again, is because the breathing muscles can get weak. One of the things our breathing muscles do is help us cough. If you can't cough, if you can't get stuff out of your lungs, whether it's mucus or bacteria, viruses, whatever, you're more likely to get pneumonia. You're more likely to keep an infection in your chest that causes you to be sick. So lung doctors are always looking for signs of pneumonia or signs that you've had pneumonia. And the thing that we do about that is, as you'll see further in the session, is airway clearance methods, but also, especially in your age group, Alex, is we use routine vaccines to keep you healthy, to keep you away from the common pneumonia bugs. One of the vaccines that we frequently use is not commonly used in kids outside of certain medical issues, including muscular dystrophy. And that's called the pneumococcal vaccine. The trade name is Pneumovax. And that prevents or helps prevent infections with 23 different kinds of pneumonia bacteria. Again, not every kid at age 10 or in the ambulatory phase gets this, except when they have muscular dystrophy. So we need to think about when is the right time. And this is all preventive. So we're hoping to prevent pneumonias. We're hoping to preserve muscle function by not letting you get sick. I think we can go to the next slide. So I wanted to talk really quickly about pulmonary function tests. And these are essentially the 4 pulmonary function tests that we do. So I'll describe them really briefly, and then I want Alex to tell us his perspective. So the 4 tests that we really pay attention to are the forced vital capacity, which is how much air can I exhale after taking a full deep breath and filling my lungs. Peak cough flow, sometimes also known as a cough peak flow, measures how fast does air come out when I cough. And that really measures how well you cough, how you can move mucus. And then the last 2 tests are pressures. We measure pressures, maximal expiratory pressure and maximal inspiratory pressures. And these measure respectively how hard can I exhale and how hard can I inhale. That really tests the breathing muscles themselves. So that's nice and dry and boring. And hopefully you've heard that from your pulmonologist or the pulmonary function. What I want to know, Alex, is how do you feel about doing breathing tests?
Well, I'm going to be straight honest with you. I don't really like them that much because I just feel like I'm pressured to do it, and I just don't like doing something that's hard over and over and over again.
And how does that compare to your physical therapist tests? Why is this one not your?
Because I have like a bond with my physical therapist, and with that, I just don't really like it, and I don't really know the people that are helping me with it.
Dawn, what's your perspective on it?
Yeah, it's interesting that you asked that. So with Alex being at the age that he is, and also just having some behavior challenges, sometimes doing things, I'm usually in the room when they're conducting the tests, probably more just to chaperone or kind of help things along if needed. And I really am pretty silent when I'm in the room. But, I think I watch him struggle through those tests, and probably why he says he doesn't like it is it takes him a minute to understand what to do. And he may be rushing through them just to try to get them done. And I've learned through observation, these aren't really ones that you can rush through because there's a certain result that we're looking for. So, just really simple. One of them is blowing out birthday candles, and he didn't realize that you had to keep blowing after that last candle. It's like one of their tricky candles that we have on birthday cakes, right? And so he blew all the candles the first time, saw the last one, assumed it was going to go out and stop. So I'm sitting there watching him have to repeat these tests a lot, so I can relate to what he said, is that he does appear to be feeling some pressure with Alex, and that behavior. Also, anxiety plays a really big role in his behavior or the outcomes. So anything where he's nervous, doesn't like it, or feels pressured to get something as a certain result, that anxiety kicks in pretty quickly. We just had our 6-month checkup recently. It was only a couple weeks ago. And this test also happened to be at the end of our time in the clinic, just through how it worked out from a rotation of meeting standpoint. Sometimes we do them earlier in our visit, and I actually see him complete them a little bit better. I think he's focused. He's excited to get to the next task. So he still rushes a bit. But this last time I watched him do them, after he'd been sitting in and out of a kind of clinical setting for about 2.5 hours, and he knew that this was the last thing that we needed to do before we could leave. And I watched him really struggle this past time, to the point where the pulmonologist who came and talked to us was kind of wondering how the results landed the way they were. And so I explained to her the situation and said, if you talk to the person, the technician who did the results, you may learn that he was being pretty squirrely during that and really just trying to get out of there. So sometimes we've learned that Alex's results on those tests right now aren't necessarily accurate, I would say. It's really driven by his desire that day to either complete or not complete those tests.
And I think that's a really important point, that we have to be able to put these things in context. Clinic visits are long, they're complicated, there's a lot of information we're gathering, trying to put together. Right? Alex, seeing your head go. Yeah. And so fatigue, frustration, attention, behavior, all these things play into the quality of the data that we're collecting. Our job as pulmonologists, and I'm mostly talking to myself and my colleagues, is that we have to put that in context. So if something seems off, we owe it to talk to mom and dad, to the patient, to the tech who collected the data, to make sure that we really understand what's going on. Because sometimes it's not what it seems. It's just that today wasn't the best day to do this. That's okay, but we do have to put it in context. So I think our time is about up. Alex or Dawn, did you want to add anything else before we go back to the studio?
No.
Nothing here.
Okay, well, Alex, I've really enjoyed talking to you. Thanks for sharing all your thoughts. Dawn, thank you so much.
Thank you.
See ya.
See ya. We'll take it back to the studio.
Thank you, Dr. Kupfer, and thank you, Don and Alex. We really appreciate you participating, and it's so great to get that patient perspective. I think that's really helpful too for the other families out there, just to kind of hear, what your lived experiences are as you go through those type of those clinic visits.
Yeah, and Alex, we're a big fan of your videos, so keep making them. I also think it demonstrated how important it is to have that open communication. And we're ready to move to the next speakers.
Yeah, and so our next speakers, we're going to be talking about sleep studies and nighttime ventilation. We're going to be joined by Dr. Richard Schell from Nationwide Children's Hospital and Varun Viswanathan. So Dr. Schell, I'm going to hand it off to you.
Great. I'm thrilled to be here as well, and happy that I get to be part of this whole conversation. I wanted to start just by saying, there's a couple of things that I thought of when they were just talking about PFTs, and I hope that, and I think this goes for any patient that's in there, please, if you're in your clinics and it's just not a good day, we totally take that into account. And our respiratory therapists, I look at them as cheerleaders, and sometimes, it's important to let them know, hey, I'm having a bad day, or hey, I'm really tired. But they're there to get the best result, but it is only a number. It's like Oren said, we take into account a lot of other factors when we're making those determinations. And usually, at least our RTs will write, I don't know if they'll use the word squirrely, but they would say something like, didn't give his best effort, we take that into close account when we're seeing them with PFTs. So some of my slides are going to overlap with Oren's a little bit because we think alike. So next slide, please. So I just add this here to talk about the fact that, breathing muscles, we think about all of our big muscles and our arm muscles and our leg muscles, but there's hundreds of muscles, in between our ribs, our diaphragm, our abdomen, our neck, and things like that, that all really affect how we take a breath in, or for inhalation, and how we exhale. And that's why we do our pulmonary function, to try to measure that strength. Next slide. This was just a little bit, we talked a little bit about pulmonary function tests, and we definitely do this as much as we can. And we're looking at different numbers to help us measure how strong these muscles are of taking that breath in and taking that breath out. And we also use our pulmonary function testing to do a measurement called a cough flow, which helps us to determine how strong your cough is and how strong that cough is able to clear secretions. And that number gives us a little bit of more information about, say you have to go to surgery and the anesthesiologist has to help you go to sleep. It does give us some information about how safe that is and what kind of precautions we need to take. Next slide. Actually, can you go back to the previous slide? The other thing that we do in our clinic is to measure carbon dioxide levels, which takes a little bit more into our part. Varun and I are going to talk about this kind of late adolescent, early adulthood part of Duchenne. And one of the things that we measure are carbon dioxide levels. And I was always taught, if the carbon dioxide level, which is the bad gas, the gas that you exhale, is elevated, and we're checking that in clinic when you're awake, we've probably missed the boat on asking you the right questions and when to get a sleep study. But it does help us kind of monitor how effective your lungs are at clearing that bad gas. Next slide. So this is really, this part of Duchenne, when we start having changes in our pulmonary function, usually somewhere in late adolescence, 12 to 17, and we start talking, the first thing that we would talk about in clinic when we see our cough flow going down is ordering something called a cough assist. And I know that many people in the audience probably have one of these. I know some of our speakers definitely have them. But these are just devices to help you clear secretions, because you do not really have lung disease as a patient with muscular dystrophy or Duchenne. You have muscle disease, as Alex told us earlier, and it's the muscles that need the help. So next slide. So Well, if you don't get anything from my part and Varun's part, chest therapy is probably the most important preventative therapy you can do with your muscles are weak. And I have always looked at the cough assist or a BiPAP machine as a wheelchair for your lung muscles. And if this works, we'll have some animation. So next slide. You turn this into a wheelchair and it just goes off. So if you think about using your wheelchair because your leg muscles can't really get you around the house anymore, the cough assist is that same wheelchair that helping to get that mucus out of your lungs that your muscles can't just clear those secretions. So I was going to ask Varun to start talking too. Varun, when we started talking about these kind of things, you have to think back to when you were a little younger. What kind of things were going through your head when we were talking about doing chest therapy and talking about getting sleep studies and maybe needing BiPAP?
Honestly, when I first heard about it, I didn't really know what to think. There wasn't much of a reaction. I mean, it seemed a little overwhelming just knowing that there were all these things we had to do. But at the same time, I didn't really know what to expect. I mean, I think at that point, I didn't really even realize that I had issues when it comes to sleeping or when it comes to coughing. I think it wasn't until I started using cough assist and started doing BiPAP that I really realized that there was much of a difference for me.
Yeah, I think that's something that a lot of our patients go through because you don't really, though Duchenne is a progressive disease, it's not always a fast progressive disease. Like we have other lung diseases where, say, for instance, a patient with cystic fibrosis from birth has to do all these chest therapies. So they're used to it when they're 5 and 6 and 7. We're coming at you when you're 15, and 15-year-olds don't necessarily want to sit down and do therapy 2 or 3 times a day. They've got better things to do. So, I think it's important, and I try to stress this with patients to, it's a preventative therapy. I look at using the cough assist sometimes as kind of physical therapy for your lung muscles to stretch those muscles to help clear the secretions when you don't even know that there's secretions down there. If you want to go to the next slide. I just threw this up there because some people do ask about the therapy vest. This is a approved device for cystic fibrosis. I think that I was just asked recently by Hillrom that they're starting to look at some studies to see if this is actually effective and worthwhile in neuromuscular disease. It's a very expensive device. And I do use this in patients who have recurrent pneumonia. And Varun, I don't remember if you have a vest at home or not.
No, I just use the cough assist and I have a BiPAP machine.
Yeah, and a lot of times, go ahead.
Yeah, we haven't used the vest.
Yeah, a lot of times we'll use this in the hospital when someone has a pneumonia, or if I have a patient who has recurrent pneumonia, sometimes this helps, but you have to remember the vest just shakes things loose, and if you can't cough it out, then it's still down there. So next slide. Scoliosis also sometimes is a problem during this period of time and can affect how you're breathing. And we start talking about the use of these devices to help clear the secretions. And when scoliosis can the best word I use is squish parts of your lungs. Sometimes the cough assist and BiPAP can help keep aerating that area of your lungs. Next slide. And then we all talked about sleep studies too. Do you remember your first sleep study, Varun?
Yeah, I remember my first sleep study. I think I noticed that they put so many things on me, including these things to monitor my heart rate and breathing, that it felt like it was a little harder for me to fall asleep during the sleep study. And I think it just felt like a pain because at that time I didn't really even think I had issues with sleeping or breathing. So I think at that time it just felt like something unnecessary that I had to do. But I think after that I started to see the benefit, and then it seemed worth it.
How long do you think that took? When we talked to you about using BiPAP and the need for BiPAP based on those results, I think we probably asked you some of the questions that are on here, like, did you feel like you were having any behavior changes during the day or feeling more tired? Sometimes I'll ask patients or families, like, does your son wake up more at night? And sometimes I wonder, like, if these wakeful periods at night have something to do, is it behavioral, is it pain, or is there a breathing problem that's causing you to wake up and then you're awake so you need help moving around? And younger children sometimes with steroids gain a lot of weight, they have more snoring, sometimes they can have more obstructive. But what we're really looking for in these sleep studies is what we call hypoventilation, or another word for that would be shallow breathing. And that's probably what we saw in your original sleep study. But when you started using your BiPAP, like how long did it take for you to get used to it? And
Yeah, I would say that, I noticed the changes in my sleep even after a few weeks or a month. I think it was just that I was so used to the way I was sleeping, and I already was a very light sleeper. So I think it wasn't noticeable until I did it. The main thing that took a while to get used to was the feeling of having something on my face. And I think after I did the study, I had to wear a full face mask for the BiPAP. I think there's just a feeling of claustrophobia wearing that. But I think after about 2 or 3 months, I got over that discomfort too. And I think I really started to see that it really improved my sleep, then I just accepted that I had to use it.
great. And I also want to make a point too, like there's so many different kinds of masks out there that if you are having trouble, if you are on BiPAP at home or CPAP, though BiPAP is really much more what we would want to use in patients with Duchenne, and you're having trouble with your mask, ask us, ask your therapist. Like we can fit for all kinds of masks, and your home care companies can get nasal masks or masks that go over your nose and mouth, or things that have gel. Like there's so many more masks out there than I probably even know about, but it's important to be comfortable on it and to talk about that when you're in clinic.
Yeah, we had to go through few different masks, and it took a while to figure out what really works. I think it's very important to try different masks. And
Yeah.
I think for me, the main thing was I noticed a difference. If I didn't wear it one day, I noticed how much more rest I got with it. It was a significant difference.
So these are kind of things that I feel like you're telling me things that have really improved your quality of life. Would you agree that BiPAP has helped you or changed your health in some way?
Yeah, I would say that has had a huge impact. Just the fact that I noticed that I get much better sleep. I notice, especially when I have a cold, sometimes even in the afternoon, I'll take a nap and put it on because it really does. It's noticeable how much of a rest it gives my lungs. I think it's something that in the beginning you don't even realize. In the beginning, you don't realize how important it is, but once you start getting used to it, you see that it really does have a major impact on quality of life. I think there's just a hesitancy in the beginning because in the beginning, you don't feel like you need that improvement. But I think it's only when you get used to it that you see what a significant difference it makes.
Well, I think that's a really good place. If you can go to the next slide, I think I just wanted to make sure I'm not missing anything, but I just had some slides to talk about. Well, we talk about BiPAP is really another word for it is non-invasive ventilation, whereas invasive ventilation is more with a tracheostomy tube. And, some of our patients do choose that when they get to a point, and I'm sure that we'll broach that subject a little bit with Dr. Sheehan and Conrad. Next slide. But my bottom line is just, getting all this information is important. Asking questions when you're in clinic with us. There's no dumb questions to ask, and just be open and honest. And we'll try to make these things work better. And there's ways to get around things. So, with that, Varun, thank you for your insight right now. And we will go back to the studio so that we can get to our next section and answer some questions.
Great. Thank you, Dr. Schell, and thank you, Varun. I think it's really helpful and important, to hear from the patient experience, and so other patients with Duchenne can hear from their peers kind of about those positive quality of life improvements. It certainly helps a lot.
Absolutely. It's a nice addition to the conference. And I think we're ready to go with our next duo. And I see Conrad Reynoldsson up and Dan.
Yes, we're going to be talking about daytime ventilation. We're joined by Dr. Dan Sheehan and Conrad Reynoldsson. So Dr. Sheehan, I'll pass it over to you.
Great. Thank you so much. We're both thrilled to be here. I'm going to introduce Conrad. Conrad is a 34-year-old disability and civil rights attorney who also has Duchenne muscular dystrophy. He earned a law degree from the University of Washington after graduating summa cum laude from Seattle Pacific University. In 2017, he founded a 501c3 nonprofit disability rights law firm in Seattle named Washington Civil and Disability Advocate. He's also a member of the Washington Advisory Committee to the U.S. Commission on Civil Rights, an ambassador on the American Association of People with Disabilities Ambassadors Council, and a board member of the Washington Attorneys with Disabilities Association. In his spare time, when there's not a pandemic, Conrad loves to go to Mariners games and most Husky sports at the University of Washington. He enjoys going to concerts, going to movies, spending time with his girlfriend, family, and friends, and being involved with the young adult ministry at his church.
All right, thank you, Dan. I will do your intro as well. Dan is a pediatric pulmonologist, or also known as a lung doctor, from Oshai Children's Hospital in Buffalo. He co-chaired the Pulmonary Working Group that developed the 2018 DMD care considerations. And since 2014, he has worked with PPMD to develop pulmonary webinars, family handouts, and videos.
Great. Next slide, please. So this is a slide that I've shown in other conferences of when individuals with Duchenne will have breathing muscle weakness that requires equipment to support either a weak cough, weak breathing asleep, or weak breathing when awake. And everyone with Duchenne is different and will need support equipment started at different times. Some boys will need a cough assist in their early teens, some not until their late teens. Very similar with support with weak breathing asleep. And then as far as weak breathing awake, some individuals will require that in their late teens, early 20s. And by age 30, many to most individuals with Duchenne will need support for all three. Next slide, please. So in this slide, what we have is when Conrad was diagnosed with Duchenne and when he began to use the different equipment. And Conrad, would you like to tell people about your diagnosis and then when you started this equipment and what led to starting this equipment?
Sure. So I was diagnosed at age 3, and then at age 14, I started using the BiPAP at night, as well as the cough assist device. And then it was around age 21 that I started using the daytime non-invasive ventilation. And so I was going to go into detail a little bit more when we get to that point with the basically from age 3 on to 14, and then around the time of the BiPAP / cough assistant machine, and then the daytime non-invasive. So I guess I can go into that a little bit more now. So with the early period, a couple of highlights of what we did didn't involve any formal devices. However, I did do daily spirometry exercises to try to maintain my forced vital capacity and cough. And that kind of took the form of my chest therapy, quote unquote, at that age. And then a couple other things that I did that I think were very valuable is I did do swimming as exercise. And I think that actually the pressure of the water on my diaphragm helped build, I guess, a little bit more function with my breathing. So I think that did help. And then also, I think range of motion and maintaining flexibility was also valuable at that time. Things were a little bit different with steroids, and that wasn't necessarily the, I guess, gold standard at that point. So I think that is relevant to kind of the age points here involved. And then, as we mentioned, BiPAP was at age 14 and started with an evaluation / referral to Dr. Bendit at University of Washington. And that was based on headaches, poor quality of sleep, that sort of thing after I had my spinal fusion at age 13, rather than necessarily just based on pulmonary function tests and CO2 numbers. But we decided to be proactive. And so at age 14, I started on the BiPAP at night. And echoing the same comments from Varun, it took time to figure out the mask that worked best. But eventually I had a nasal mask, and I've basically used that ever since. And leading up to switching to the BiPAP, I had issues with poor appetite and weight loss, and also anxiety, I think, because it was harder to breathe. However, once I started on the BiPAP, it was a night and day, if you'll pardon the pun, difference in sleep quality. And I think I was very fortunate at that time, because often the standard was to just wait for a crisis and then deal with it with something more invasive. However, thanks to Dr. Bendit, we didn't take that approach. And highlighting that that's also been a problem with a lot of people with cardio as well. Again, proactive is the most important thing. And so at that time, there was also the cough assist machine, and it was helpful, especially when I'd get colds as a teen. And I did have some bouts with bronchitis as a result of some of those colds, but I did not have any hospitalizations, which made a big difference. And then also during that time, thanks to Dr. Bendit, as well as the late, great Louis Boitano, his RT, we also used something called an ambu bag and did that as kind of my chest therapy. And so I would daily use that instead of the cough machine. But again, it was kind of something called breath stacking, where you take multiple breaths on top of each other to really stretch out the diaphragm, and that made a big difference. And then also I continued with swimming during my teenage years, which again, for the same reasons, helped. And then lastly, getting to the daytime non-invasive stage around 21. Leading up to that, I was again dealing with a little bit more with appetite and weight loss at that time, anxiety and shortness of breath. But again, these symptoms were really ahead of any indications from the pulmonary function test or CO2. I won't go into all the details about it, but ended up resuming steroids around that time as well. And I think that definitely ended up being very helpful. And again, those symptoms went away once I switched to daytime ventilation and figured out how best to use that. And I would also mention lastly, that's kind of my preferred method over the cough assist machine. And I find that it's easier for me to use that. And breath stack, taking multiple breaths because there's more control over it. So that is something to consider. Okay, so I think that's my high level overview.
Okay, good. Next slide, please. So as you've heard from all of the speakers, for weak cough, it often occurs without symptoms. And so we really do use pulmonary function testing to help us decide when a cough assist might be needed. Some individuals may have a persistent chest congestion or rattling, or you may hear throat clearing, which is as deep as a cough as someone can take. They've spoken about weak breathing with the sleep as far as the signs and symptoms. Like, I think in addition, if there's a change in school performance, if there's daytime naps, morning headaches, sweating with sleep, requiring a lot of repositioning, that usually warrants a sleep study to see what's happening to body oxygen and body carbon dioxide with sleep. And then with weak breathing awake, if individual is short of breath, as Conrad has mentioned, sometimes the voice will soften because you can't get a big breath behind your voice. And then some individuals will actually start speaking in short sentences because they need to take breaths in between in order to complete a full sentence. Next slide, please. So you've heard about CPAP, BiPAP, and ventilator. And so just as a review, CPAP is one continuous positive airway pressure, really designed to keep the throat open. It's what we use for obstructive sleep apnea. And some younger boys with Duchenne need just continuous positive airway pressure. BiPAP is bi-level, which means two pressures. There's a background expiratory pressure that keeps the airway open. And then there's an IPAP, an inspiratory positive airway pressure that helps individuals take bigger breaths when they sleep. And then the ventilator may be either giving you a pressure breath or a volume breath. And we use the ventilator for sip breaths that you saw that Conrad and Varun was using. Next slide. And if you look behind either the chair or the wheelchair that Varun and Conrad were using, you would see the ventilator and the mouthpiece that allows them to take that deep breath and stack breaths when they want to. Next slide. So our real big takeaways are be proactive, not reactive, have the pulmonary function test monitored, share your symptoms with your care providers, and really communicate with them. Ask those questions and share the challenges. None of this equipment is always easy the first time, and there's always some adjustments that can be made. So, Conrad, any other last thoughts?
Sure. Yeah, a couple of things I'd highlight is, just like what Varun was talking about, it's, it all gets back to quality of life. And so I think all of these things should be viewed as things that, are helpful tools, but also being aware that, it's a process of dealing with these things. And it's kind of much different than someone who has, an injury that results in a disability where they just have to go through the, grieving process, as it were, one time versus having a progression to deal with. However, analogy I was kind of thinking about when I was thinking about this presentation last night was my experience of using a power chair for the first time, and how a lot of people were worried about, how I would take it and just how well I would deal with it. But I remember the first time I got in that chair that, I fired it up and saw that the joystick was just like kind of an arcade machine to me. And, it was age 10 when I stopped ambulating. And, I took off and drove around in the chair in the shop and was going fast again. And for me, I was able to look at it as, liberating things so I could keep up with my friends again and, be able to play like another kid, just different mode of transportation. And so if there's a way to look at it, again, as quality of life with some of these things and liberating, I think that's really healthy. And, once I started using daytime ventilation, for example, I really had kind of a sense of ease and freedom going places and traveling and not worrying about, feeling like I couldn't breathe very well and things like that, and just being able to enjoy life more.
Okay, great. Well, let's go back to the studio and open things up to questions.
Thank you, Dr. Sheehan. Thank you, Conrad, for sharing your journey and your really positive outlook. It's great to kind of hear those experiences. As we head to the panel, just a reminder, if you do have questions, you can submit them to the comment box below. And as we come to the panel, we are going to be joined by PPMD's Vice President of Clinical Care and Education, Rachel Schrader. And so with that, Rachel, I'm going to hand it over to you.
Great. Thank you so much, Eric and Ryan. And thank you to all of our speakers. I love these interactive sorts of panels. I think that, hearing directly from the guys just gives a really different perspective for our listeners at home. We all listen to the doctors talk and they've got lots of wisdom, but I think that additional perspective can really make a difference, particularly if you're in a time of transition and thinking about, getting your first sleep study or, using a BiPAP for the first time or whatever the case may be for you at home. So we do have a handful of questions, and we'll try to get through as many as we can over the next few minutes. I know that we talked a lot about the use of BiPAP at night, and how that this can be a really helpful tool. But Dr. Schell, can you talk a little bit about the difference between BiPAP and CPAP? The question that we got was, does CPAP have any negative effect on the lungs in the long term? This is from a mom who said, her son wasn't really able to tolerate the BiPAP, but he did seem to be able to tolerate the CPAP a little bit more easily. And so what would you say to parents who are perhaps kind of wrestling with that question?
So, it's a great question. And I don't ever say that we never use CPAP. And I'm sure that Dan and Warren can chime in here too. But, for a younger child who has just pure obstructive sleep apnea because their tonsils or adenoids might be big, and they have a tonsillectomy and they're still having some problems, CPAP might be an okay choice there. But we do know that the main problem is hypoventilation. And if you're breathing shallow and your carbon dioxide, the bad gas, is going up higher when you're sleeping at night, BiPAP really is the best choice. And if a patient is having a lot of trouble tolerating that, we can work with the settings. There are settings that you can ramp up. So you start really low, and as they fall asleep, the machine kind of takes over a little bit more. There's a lot of tricks to the trade, and using some of our sleep specialists to try to answer that. But really, in neuromuscular disease, BiPAP is really what we would choose over CPAP. But I would never say never. Like, if CPAP is correcting the problem and they're tolerating that well, I wouldn't tell someone to switch necessarily.
Dr. Cooper, Dr. Sheehan, would you add anything to that? I think that's a really helpful explanation. Okay.
Yeah, I agree with Richard. I think we talk in absolutes that BiPAP is what we're supposed to do, and then we have to come to the real world and see what our patients can use and do what they can do, and eventually maybe get to the ideal state. But it's all about making those very dry guidelines work in the very real world.
Totally agree. And sometimes individuals will start with CPAP because things start out as obstruction, and then in the later teens, they will be switching over to the BiPAP. So if you didn't have success initially with BiPAP, 2 to 3 to 5 years later, be open to trying it again.
Great. Thank you so much. All right. So this next question, I'm going to start with you, Dawn, and then perhaps Varun or Conrad could pipe in, or even our doctors. But the question is about PFTs. So what advice do you have for other parents who are encouraging their sons for PFTs leading up to that clinic visit? I know that you and Alex worked really hard to be successful and be prepared going into clinic, and I'm sure that this is a conversation that you have. So what do you guys talk about? Do you do anything at home? Do you have any rituals? How do you guys prepare?
Yeah, that's a good question. So with Alex, and I'm sure other children just in general, we talk about what we're going to do. So we kind of prepare and prep. So, hey, okay, here's your upcoming clinic visit. And I'm guessing these are the things that we're going to go through. We'll see when we get in the room that day. So just reminding him that he's going to have to do that sometimes just starts to get him to begin to process that a little bit. I think you may have heard him mention that he has a bond with some of the clinicians, and he's developed that over time. We have a physical therapist that he sees pretty often there that he's really quite adores. And they've developed a great routine together where there's a reward for him at the end for completing some of those tasks. So I would, throw that out to the clinics actually as a suggestion, because there are some kids, Alex is one of them, that are taken to something being out there at the end. So we've talked about kind of a reward process for that, for successfully completing that. And then I think you also heard me mention that I watched him struggle a lot this most recent time because that test was at the end. I think next time I'm going to reach out to the clinic ahead of time and see if we can set it up so that he sees the therapist first, because that's when he's excited to be there. He's going to be probably the most engaged at that period of time. And I think that it could be a thought from a parent perspective just to partner with the clinicians that day, because you know your child the best, and to try to determine what order of events lays out that day possibly best in terms of what you think the results could be like. So next time I'm going to see if we can stack that a little differently and see if we can knock out the one he doesn't like first and kind of get it out of the way and see if we can't get him to focus and be a little bit more engaged in that process.
Dr. Cooper, would you add anything to that as you talk to patients and prepare them for what this experience is like?
Yeah, I think it's really important to take into account how a kid thinks about their very long and very detailed clinic day. I'm wondering if one of the things we can do from a clinic perspective is share the schedule, what we think the order of operations is going to be for that day, so a child and a parent can prepare for what's coming next. That's something that we try to do in our clinic here in Colorado. We sometimes throw it out the window when things don't go as planned in the clinic, but we try to have a schedule for every single patient so that they know what's coming and what to expect. Don, I don't know if you think that would work for Alex as another alternative.
Yeah, so when we walk into clinic, we are, greeted and taken back to our room for the day. And at that time, the nursing staff writes our schedule for the day on the board. But I imagine you all would know this best, that sometimes those behind the scenes schedules get shuffled a little too in terms of doctor or therapist availability. So we do get an update as to what our schedule is going to be for the day. We get it when we go there. So I'm hearing what you're saying, and possibly there's an opportunity just to know that a little bit ahead of time as well. But I'm imagining from a clinic and a staff perspective, everyone's juggling behind the scenes as they're shuffling multiple doctors and therapists in and out of rooms as well. So to the best that it could be managed, it would be great to know that ahead.
Dr. Schell, would you add anything?
Yeah, I just had two short comments. One, I think that we all have to remember that the pulmonary function test is just a number. And I think that it gives us a lot of information moving forward, but none of us on here are going to make a decision based on one pulmonary function test. We're going to ask more clinical questions. And I feel like someone who's clinically doing well with one bad number is not anything to worry about, and we'll get to it. But it comes from clinic flow, and I know that I'm at that center, so I appreciate all this feedback. COVID has thrown a wrench into a lot of our clinics. So this past year has been really difficult, especially because a pulmonary function test is considered an aerosolizing procedure. So we had to close down rooms for a certain amount of time based on how the filtration was. And our therapists, now we don't close our rooms down anymore, but we're still wearing full COVID N95 masks and things like that when we're doing the pulmonary function test. So it should get better, but we certainly welcome any patient. I'm talking to anybody out there listening, when you get to your clinics, if there's a big plan, if there's something that will work better by doing it first, absolutely let the nurse know that's checking you in, let us know. And we'll make it happen, because a lot of times our PFT, our respiratory therapists are just waiting there for the nurse to say, okay, you can do this, you can go do this person now. But there's always room for adjustment, especially when in a clinic like ours where you're seeing 10 different types of practitioners, and we're trying to get that in a short period of time. So, I think that, learning this from a doctor standpoint too, we can go and help with that as well.
Great. Thank you so much, Dr. Schell. I have a whole list of questions here that we did not have time to get to, and I'm really disappointed because I think that there's opportunity for some really, really great conversation. So I wonder if we won't have to follow up with maybe a post-conference pulmonary webinar for the community and extend this conversation. But thank you to all of our wonderful physicians and our patients and parents. I think this has been fantastic. I know that I always learn so much hearing from that parent and patient perspective.